Provider Enrollment 104. I would like to introduce our presenter for today, Yesenia Servin. Yesenia Servin, CBMS, PESC, is an expert in credentialing and provider enrollment with over 27 years of experience in healthcare industry. I would now like to hand over the floor to the speaker. Over to you, Yesenia.
Thank you so much, Christine, and thank you everyone for being here. So today we're going to identify, some requirements, some documentation, some provider enrollment, what it looks like across several plans, and we're going to talk about the reporting and rostering. And so a lot of it also has to do with understanding the language and understanding each piece of the process. Credentialing is actually verifying that provider's credentials, verifying their education, their work history, all of their expertise and training, the board certifications. And so provider enrollment is a process of getting all that credential information and completing either payer applications, whether that's on a portal, whether that's web-based. So an employed physician is a direct employee, right, of the organization. So APP, yes, they can serve. Yes, they're mostly independent, mostly because we need the collaborative agreement and we need the physician to be, supervisory. A locums has a 60-day period to work in your organization under your physician's NPI. And so now let's dig into payer enrollment, delegated versus just straight provider enrollment. The NPDB considers delegated credentialing when a healthcare entity gives another entity the entire process of credentialing. So a provider entity would be, the clinic, the group, the facility. And so some of the things that, you'll see in the handouts is you'll have an example of what a delegated agreement can look like. What are the things that are going to be required on those rosters. NCQA is the regulatory body for insurance networks in the U.S. So good for you to know this and have this. What does that look like in terms of compared to individual applications? The other nice bonus about having delegated agreements is that delegated agreements don't require CAQH profiles be kept up to date. They don't require it at all. And CAQH recently had a change. I'm sure you all saw that if you logged in this month. You're doing one or the other of these tasks. You understand the deep connection between both stakeholders, right? We're touching the same information, whether we're doing one or the other, we're doing both things. What do we need to do if we want these delegated agreements? And this is for all of you that you're already past 101, 102, 103. You're going to dig into it so that you can make it more efficient and work better for you. Just make sure that you're understanding what the language is and where you're categorizing them. From this delegation agreement here, we're looking at it right now from a provider enrollment point of view. And then there's a lot more NCQH language. Some of the things that you have to consider when you're at this 104 level, how many providers are we at? Every plan is different. Usually the baseline is 200. And then what are the provider types? Are they acceptable to that specific delegated agreement? Green, yellow, obviously green go, yellow caution, red stop that you need to review when you're going through this delegated credentialing process. Audits are huge, and as part of your handouts, there is an auditing tool so like I mentioned, you're going to do the self-audits yourself. So now that you've passed the audit, you're going to jump into the delegated agreement. The legal team has reviewed it. Wonderful for you. You got the green light. You did your due diligence. You did a great job. You did the credentialing and enrollment pieces perfectly. All of these things have to be reviewed, specifically Medicare opt-out information, and you have to have a credentials committee, right? Because this is part of that NCQA standard, that the process and policy includes a modality. This will be part of the auditing process. Is your credentialing platform providing the correct reporting? For Medicare, let's jump into something completely separate. Like I mentioned last time, 104 will have a lot meatier information, a DME or a Medicare Diabetes Prevention Program supplier. It begins with CMS INA. So this is what it looks like, very easy. And you see how dated it is, extremely dated. Same thing, this is for an individual. Biggest thing, par status, yes, include a 460. And then these are direct checklists from CMS. The other thing people get stuck on is the authorized official and delegated official. Very specific breakdown based on the type of organization, very unique. So make sure that depending on who you're working with or what organizations you're working with, same with home health, very specific. Revalidations are huge. Do not miss this. Site visits are huge for revalidations now, especially if you have any change. Here's a breakdown of what you need to report. And for an 855B entity, same thing. This is just some information, hot information as to why these things happen. Trigger a fine. Like I mentioned, you are never going to have a provider manage all of their portals and profiles themselves. This has a breakdown of what this means for you, updated continuously. PICOS, we went through that thoroughly. CAQH ProView, and it's now no longer called ProView, it's called the Provider Data Portal. Thank you so much, everyone, for being here. But thank you so much and have a great weekend.
Thank you, Yesenia. That concludes the session for today. Thank you everyone for participating. You may all disconnect now and have a great weekend.